Okay, I think we'll go ahead and get started. So I'm going to um, turn it over to Chad Smith for our welcome for the evening.
Good evening, everyone, and thank you for taking time out of your very busy schedules to join us this evening. This is our quarterly OPQIC meeting for the month of October and the second fiscal quarter. And again, we appreciate you and your commitment to improving women's and newborn health for the state of Oklahoma. For those of you that don't know me and aren't familiar with me, I'm an OBGYN by training and previously at the University of Oklahoma, and recently, well, not recently anymore, several years ago, transitioned to administration at Mercy Hospital, Oklahoma City, where I continue to practice as an OB hospitalist, but primarily serve as the chief medical officer and help Barbara and the health department with medical directorship for the OPQIC. So again, just appreciate your time and efforts and understand that this is a time commitment. And so definitely appreciate that. And I know we have a jam-packed agenda. Barb, I don't know, do we want to go around and do quick introductions or just jump straight into it?
I think we need to go ahead and jump into the agenda.
All right.
Um, so thank you, Dr. Smith, and just wanted to say hello from Barbara O'Brien and the folks at OPQIC. Here's just an overview of our agenda, and if everyone can please ensure that we know who you are by what you have entered in as your participant name. You can rename yourself by hovering over your name and right-clicking and clicking and changing your name so we know who you are and where you're from if you're able to do that. So I'm not going to go into the agenda. Everyone should have received that, but if you'll go to the next slide, Denise, and I'm going to turn it over to Joyce Marshall, who will provide updates from the Oklahoma State Department of Health.
Great, thank you, Barbara, and good evening, everyone. We have just a few updates for you, and then I'm going to turn it over to Dr. Verbies to share a resource from the National Maternal Health Learning and Innovation Center, and to Dr. Stanley for more on the latest from the Oklahoma Maternal Health Task Force work groups. So first, I know many of you have probably already received this information, but just because of its importance, wanted to assure the message was out in regard to CDC's urgent health advisory to increase COVID-19 vaccination among people who are pregnant, recently pregnant, trying to become pregnant, or might become pregnant in the future to prevent serious illness, deaths, and adverse pregnancy outcomes. The advisory strongly recommends the COVID-19 vaccination either before or during pregnancy because the benefits of the vaccination for both pregnant persons and their infant outweigh the potential risks. According to CDC, only 31% of pregnant people have been vaccinated against COVID-19, and vaccination rates vary greatly by race and ethnicity. Highest among Asian and lowest among our Black population. Through September 27th, there were more than 125,000 confirmed cases of COVID-19 in pregnant people, including more than 22,000 that were hospitalized and 161 deaths. And 22 of those occurred in August alone. Also, cases of COVID-19 in symptomatic pregnant people, we now have a twofold risk of admission into intensive care and a 70% increased risk of death. They're also at an increased risk of adverse pregnancy outcomes, including preterm birth, stillbirth, and admission into the ICU of a newborn. In 2021 in Oklahoma, we have sadly already had 5 COVID-19 related maternal deaths in our state compared to only 1 last year. So it is of great concern, and just wanted to make sure you did have the latest information and that we try to help us get the word out to protect our Oklahoma moms and babies. Second, I wanted to tell you, and if Denise, if we can flip to the next slide, yes, and then we'll flip back. But Speak Up Racial Disparities Training is now available for all Oklahoma Maternal Health Task Force and Oklahoma Perinatal Quality Improvement Collaborative members. This eLearn program provides racial disparity training, and it's 3 45-minute sessions, web-based programs, self-paced. The modules include the first modules, trends on racial disparities in maternal mortality and morbidity. The second module is more about recognizing bias, inequities, and racism. And the third is in relation to speaking up. And I know this is something that was requested, and we are now able to provide. We had 175 people sign up for our first slots that were available. Those were filled, and now we're receiving a second group of slots. So I just wanted to make sure that's all available. The flyer will go out after the meeting. But if you are interested, please sign up through OPQIC, and you will also receive CME credits are available. You can flip it back now in relation to, I also some resources I wanted to let you know that will be coming your way. The 2021 annual report on maternal health, morbidity and mortality, the updated Oklahoma Maternal Health Task Force strategic plan profile, and the Oklahoma Maternal Health Data Catalog are now going through publication process and will be available very soon. We will be able to get that out to you as early as the end of the month, but for certainly within the next few weeks. And you will receive an email to alert you when those are available. They will be posted on the OSDH, Oklahoma Maternal Health Task Force, and OPQIC websites. So they will be available for you to use as a resource. Another item that I just wanted to share is in relation to infant mortality rate. So I just wanted to make sure, since we have some good news to share in that regard, that the infant mortality rate dropped 18% since beginning the statewide infant mortality reduction program and the Preparing for a Lifetime, It's Everyone's Responsibility initiative. For 2018 to 2020, we are currently at our lowest infant mortality rate of 6.7 infant deaths per 1,000 live births. That means approximately 50 more babies each year are able to spend their first birthdays with their families. And we know we still have a long road to go, but we're encouraged with the direction that we're heading. And now we need to spread this success to include our mothers and equity across all races and ethnicities. And finally, I have a nice surprise for you. My friend and colleague, Dr. Sarah Verbeest, the Executive Director for the Collaborative for Maternal and Infant Health at UNC School of Medicine and the Director of the National Maternal Health Learning and Innovation Center, is joining us today. She's going to share just a few words and also do a quick demo of the center's website, which is another great resource and tool for us in our toolbox. So Sarah, turn it over to you.
Thank you. I am so excited to be in Oklahoma, kind of, this evening, and a chance to really listen and learn to the great work that you're doing. Definitely Oklahoma, when we look across all of our maternal health innovation states, Oklahoma is always a star and always participating and really leading the way. So I am lucky to be one of the co-directors for the Maternal Health Learning and Innovation Center. I am excited to show you all the resources we have on our website. I can't share my screen. So if someone could pull the website up, I can talk you through it. The website is maternalhealthlearning.org. And if other people want to pull that up, I can put it in the chat. We are funded by the same mechanism that is funding Oklahoma's maternal health innovation work. And our role is to support you. We are your training and technical assistance team. Maternal, I can't talk and type.
Denise, can she share her screen?
Sarah, we did.
Oh, now I can share it? Okay.
So you're able to share.
Would you mind doing that? Because my computer is not letting me. It's new. This is a technical day. Thank you. I'll just walk you through it. And you all have the link in chat. So if you want to follow along or look along, thank you. So, so this is our website. And the first thing that I want to point out is our resource center. And thank you. If you want to click that, we didn't practice this, but I know we're going to be good. So here's our resource center, and you can, easiest way to search is to type in that search box right up there. And you will get a whole series of different things that would match that. You can also search by different categories such as equity, clinical care, telehealth. So we've got lots of different categories, but usually when I use this site, I just type in a couple of keywords and the resources will pop up. And we do have permission to share these. And I believe currently everything on here is open access. And we are continuing to add items to this all of the time. So we wanted to first of all make sure that you're aware of that. And then if you wouldn't mind to click on the events on the top tab up there. Thank you. So this is where we keep a list of our events. We are recovering because September, as you know, we all had a lot of extra money. So we had a lot of events. So we don't have anything currently on the calendar, but all of our events are here. We do have some featured recordings that are there to share. So you'll always find something here, either something coming up or resources to share. We have been doing a lot of recording, interviews, and podcasts with lots of different voices and perspectives to help us all really think about our work from a lot of different perspectives. If you could click on the blog. So the blog is also something that is off and running. And if any of you, your heart is calling for you, that you really want to share a resource, a tool, an idea, let Joyce know and we can connect you. A blog is a great place to do that. You can also search the blog, but here is an example of what it looks like. Over the summer, we worked with 5 different partner groups that represented really diverse populations. And so they, as you can see, they provided some blogs and resources for us that are all brand new there. And then if you go to the homepage, we did have our National Maternal Health Symposium at the very end of August, and I'm really excited. If you scroll down just a titch, there we go. All of the videos from that symposium are available, and I want to thank Joyce, who presented with myself and Belinda Pettiford from North Carolina. So you'll be able to access all the videos and all the plenaries, and there were a lot of sessions. It's all free, and you can get that there. We also are in the middle of launching an innovation podcast series, and we are releasing those every other week at this point. We also have a leadership series that we recorded that's coming out. And we also have done a series of communities of practice where there's a topic that different states or teams want to talk about, share expertise, get some extra support. And so we're creating communities of practice. And those are open to you as well. So we share information with Joyce. I know she gets it to you. You also can sign up for the newsletter if you want to get those alerts directly, if you don't have them already. And I think if you just scroll down, one last little thing to show you, we have a section to talk about different highlights. And if you scroll down, that's how you can get to our newsletter. And then you can also talk to us. So if there's something that you didn't see on there that you're interested in seeing or something that you want to share, you can just let us know. And then this is where you can see feed from social media. I personally have some help with my Twitter account. So sometimes I just go here to figure out what's happening in the Twitter world. So that's just a quick tour of the website. There's a lot of resources there. We hope that they're useful, and we want to continue to be of service to all of you and the excellent work that you're doing. So that's all I had. I don't know if there's any questions.
Thanks,
Thank you.
Sarah. We
Thank
will
you to my
add-
navigator.
I will add that to our, I think it's already on our website, but we'll make sure that there's a link and maybe have a page with different things people could link to. So
Thank you.
And it'll be on the link for the Maternal Health Task Force OSDH also. So lots of avenues to use it as a resource. Thank you, Sarah, for sharing. Appreciate that. Now, Dr. Stanley, I believe our co-chair for Oklahoma Maternal Health Task Force, is going to share update from the task force and work groups.
All right. I don't know if I'm showing up on here or if you can hear me or not, but I'm going to talk to you about the different committees on the task force. And the first one is the access to care. And we actually sat in on this meeting, which was incredibly informative. And we had a group of people in charge of some of the federal, the FQHCs in the rural parts of the state, and just discussed the difficulties in access to care and providing prenatal care and deliveries in the rural areas of Oklahoma. So we got all of their different perspectives, and I think the group is working on providing access to care. Talked about the importance of telemedicine and other ways to provide access to care, and then actually just looking at how do we provide specialty care to those rural areas. So it was quite informative to me, I think, as well as to other people, and really just have to look at what is the model of care that we're going to provide going forward to allow access to those in rural Oklahoma. On the other group, Group B, mental health, substance use, and social services. Again, looking at the access to mental health care services in the state of Oklahoma. One of the priorities there was the women who are incarcerated with drug rehab and substance use disorders. That's kind of really a pertinent problem right now. Through ACOG, we've actually had people talking to us about whether we would join in support nationally. In Oklahoma, we now are starting to charge women who have poor pregnancy outcomes and have used drugs during the pregnancy, and putting them in jail for this. And we feel like it's really a difficult situation because it's going to prevent women who have substance abuse disorders from obtaining prenatal care. So we're working on that from a political situation, as well as Group B investigating provision of care and help with the women who are incarcerated. Group C is innovative technology and data systems. Really the priority there is working to provide access to telehealth and improvements in the provision of telehealth throughout the state of Oklahoma, and to make sure that healthcare is reimbursed for. So they've been looking at ways with the healthcare authority to provide coverage going forward that way. Also helping to coordinate data systems within the state of Oklahoma to kind of integrate those health systems so we can gain as much knowledge as possible and use the information that we have. Group D is racial disparities, and mainly it seems like just bringing together the different groups that are helping to highlight the healthcare disparities, racial disparities within the state of Oklahoma. And I think to help to promote those people, to promote more, what would I say, racial disparity in the provision of care in the state of Oklahoma. I think that's the big thing that way. If anybody from any of those groups have any other comments, speak up now. But I think really mainly gathering data, but I think what we're doing is starting to see the holes where we need to provide support within the state of Oklahoma in these areas. Nope.
Thank
Hey,
you.
Barbara?
John, this is Gina Moore. I'm with
Yeah.
Family and Children's Services, and we have the neonatal abstinence syndrome grant. And we work within 6 rural counties that are contiguous to Tulsa. You know, I'm with Women in Recovery and Women's Justice Team. And we are working with women of childbearing age that are of high risk for substance use within the rural county jails, as well as David L. Moss. So I'm really glad to hear that you're talking about the women that are incarcerated that are pregnant, because they do need those services. And there's really nothing out there, even when they get out, but just bringing that awareness of the things that they need while they're in jail as well. So I'm really glad to hear that.
Yeah, I don't know how far we're going to make it on providing help for those women, because all of them that I talk to that are incarcerated for drugs or
Mhm.
substance use disorders, and those that have gotten out from incarceration, when I ask them if they got any help within the system, it's pretty much a unanimous no. And so I think it's a huge area, and I appreciate your help in that area.
Yeah, because we really are there to provide them linkages to services. Of course, if they're able to get into Women in Recovery, we have a clear pathway to them, as well as we have provided some iPads in some of our jails if they'll take them, so we can refer them on and also do some services while they're in jail. But just that continued care within their community, if it's possible, just that location of services, so we can get them in as soon as possible. Yeah.
So are you hooked in with the group?
She's a member of our group. Yes.
Good,
I
okay,
am a
great.
member of this group.
Good.
She
Good.
is
I
very,
appreciate
so
it.
that's, Gina's one of our great resources, and we have made some connections with the Department of Corrections and with the Sheriff's Association, and talking about how we can ensure that these pregnant people are identified and provided with the resources they need while they're in jail or in prison, and then again continuing services upon release. So thanks so much for sharing. Jacqueline just put an example of a case in Oklahoma incarcerating pregnant women. So we will learn more coming up here and in one of our later presentations about a different approach for these people, and hopefully it will we'll learn how what our plans are to provide a supportive environment instead of a punitive environment. So
I think the other thing to mention as far as the maternal health task force, there's a couple other things we're kind of working on peripherally, and one of them is legislatively to make it seamless to receive 1 year of postpartum care with the expanded Medicaid system, and trying to make that work well. And then the other thing we're looking at is trying to get everybody, the maternal mortality, we're still missing a lot of people, and get the medical examiners to help us to collect the information on that and consider autopsies on the pregnant women who have died, possibly of unknown causes.
Yes, that is a legislative priority. Um, Anything else, Dr. Stanley? Thank you.
Thanks.
Joyce, do you have anything else to share?
I think that's it for now. Thank you, Barbara.
Okay. Next, then, we're going to move to Trailer Rains, the Deputy State Medicaid Director, who's going to provide some updates from the Healthcare Authority.
Hi, good evening. I will share my screen here real quick. Just a small presentation for you, just around updates with our Medicaid expansion so far. Okay. All right, so as of today, we are at 193,616 members enrolled through expansion, which is just phenomenal at this point. We're about actually where we thought we were. For the first year, we did anticipate we'd hit around 220. And so a lot of these, if you look at the next slide, a lot of these members came through those who were previously enrolled in other programs like Inter-Oklahoma, or another benefit that was less rich as the expansion benefit. And so those roughly 68,000 individuals, we transitioned over to expansion pretty much on July 1st, on day one. And so the others are individuals who are newly eligible, would not have been eligible for any other benefit until we expanded Medicaid on July 1st. This just gives you a snapshot of where we're seeing these expansion members come through as far as the various counties. Of course, the two metros are going to be the most highly populated, but just kind of gives you a snapshot, and I'll share these with the group afterwards so you can take more time to look at it. A snapshot on where these expansion members are being served. And really, this next slide shows you, on average, our per member per month cost for an expansion member is $688. And so if you look at this, you can think of the money that's going to be going into these communities. Oklahoma County, that's 34,000 individuals roughly with that PMPM. That's money that's going to our local healthcare providers and compensating for care, which would otherwise have been uncompensated for in our various systems. Breakdown of male versus female, we're seeing, of course, more females enrolling, which is the study shows is right on trend with the rest of the states that have expanded. Below, it's kind of age banded. I think something to point out here is that we're seeing the 25 to 34, we're seeing a lot of enrollment with that population so far, which is great because traditionally those individuals have kind of been those young and invincible folks that don't feel like they need to be covered. And so we all know that's not true, and that one medical emergency could put you in bankruptcy. So glad to see them enrolling. We've also got broken down by race groups, average per member per month. We're seeing, our American Indian population and our tribal providers are really doing a good job in outreaching to those folks to get them enrolled. Right now, we're about 14% of total expansion population, which Title 19 usually runs around 12%. Our urban-rural split is roughly 60-40%. As far as claims, sorry, I'm jumping around a lot here. As far as claims, we're seeing roughly 37% of those that are enrolled are actually receiving services and being reimbursed for services. But of course, we always have to give the caveat on claims lag. So providers aren't always timely. They have 6 months to file their claims and to get those in. So we expect those numbers to update as we go through. We'll talk about, let me stop sharing. I want to talk about benefit plan because I've had this question come a lot, especially with women in their postpartum period. Since we have expansion, there's going to be a seamless transition now. And so there's been a lot of talk around the American Rescue Plan and extending postpartum period for those women that have had their children, but really they'll slide back into the expansion benefit and have that available to them. And we do mirror in expansion, we mirror the Title 19 Medicaid benefit. So they will receive the same services they would have received, if not, in fact, more during that postpartum period. A quick update. I know a lot of the conversation this year has been around managed care. We're still kind of in a waiting holding pattern there. As you all know, the Supreme Court pulled the plug on that, so we didn't have authority around June this year. So in the meantime, we're working on doing a redesign of our patient-centered medical home. which is really just focusing on changing those outcome measures that we use when paying providers their sooner Excel payments, their supplemental payments for pay for performance. There is a legislative leadership committee that is meeting, in fact, met yesterday to talk about steps forward and where compromise can be made around managed care versus third-party managed care or other models around care management. So we continue to have those conversations. I fully expect that probably to get finalized during this next legislative session. But right now we're focusing on the day-to-day tasks as we wait for direction to move forward on that. So happy to answer any questions if you have any.
Thanks so much, Trailer. Any questions? You can put them in the chat or take yourself off mute. Thanks, Trailer. And if you'll send us your slides, we will add them to ours, and these slides will be available on our website for you all to have access to. So thank you very much. Wanted to provide 2 quick updates from OPQIC. Ensure that everyone is aware of the information that was released in August from CMS, that they have added a CMS maternal morbidity structure measure in the hospital inpatient quality reporting program. So this is for all hospitals that are participating in the I'm looking to see what exactly it's called again. Can't find that exact, but any hospital that prevents data into hospital compare, beginning with this quarter, your information will need to be entered next year for whether your state, does your hospital or health system participate in a statewide and or national perinatal quality improvement collaborative program aimed at improving maternal outcomes during inpatient labor, delivery, and postpartum care, and has implemented patient safety practices or bundles related to maternal morbidity to address complications including, but not limited to, hemorrhage, severe hypertension, preeclampsia, or sepsis. Every hospital is going to need to answer either yes, no, or not applicable, meaning your hospital does not provide inpatient labor and delivery care. So we have a post on our What's the Latest where you can find a link to more information. And this was released again in August from CMS with their inpatient prospective payment system, the IPPS final rule, and it could impact your reimbursement rates beginning in 2023. So they are asking every hospital to submit this measure regarding this current quarter for October through December for 2021, and then this will be required to be submitted annually after that. So I wanted to make sure everyone's aware. You might want to go to your quality people, whoever reports this measure at your hospital, because you all will be likely your hospital does report this information. And now I'm going to turn it over to Sarah. If you'll go to the next slide, Sarah Johnson is just going to provide a couple of quick updates as our patient partner.
Thanks so much, Barbara. Yeah, we can go to the next slide. I'll just real quick give a quick update. First of all, I want to say that we have developed a patient partner agreement. So our patient partners that join us and participate in our patient partner network with OPQIC can sign an agreement with us, and it allows us to compensate them financially for their work that they do with us, the different types of work that they might do with us at OPQIC. So that's an update for you guys with the patient partner network. And then I just wanted to give a quick reminder that our Empowering Pregnant and Postpartum Patients Toolkit is under final review and development. We're about to have that live. However, in the meantime, all of the tools are live on our website. You can go to our website to get links to all of these resources, the urgent maternal warning signs, the post-birth warning signs, and then the OPQIC helpful post-birth resources and the clinical summary. You can go to the next slide. This is the helpful post-birth resources. And we just want to highlight this one because this can be used now and along with the others. You can get this from the link on your screen. And whenever you give this to patients, they can use the QR code to take them to our website and to receive more resources for support for them. And I think that's all I had, Barbara.
I think the next slide shows the page on the website.
Oh, sorry. The next slide, please. Thanks, Denise. This is what it looks like whenever they go to the QR code. They are brought to this page, and then they can click through the different patient resources, whatever they're looking for, and it gives expanded lists of things to help support them and whatever need they might have. I think that's it.
Thank you, Sarah.
Yeah, thank you.
Does anybody have any comments or questions? So look for more information soon about the Empowering Pregnant and Postpartum Patients Toolkit, and we are finalizing that. Next, I am going to turn it over to Amber Weisseth and Tricia Short from the Delivery Decisions Initiative at Ariadne Labs. And Amber is the director of the Delivery Decisions Initiative, and Tricia Short is the Clinical Implementation Specialist. So they're going to share their screen and give you an update on where we are right now with Team Birth and our first cohort of hospitals in Oklahoma.
Great, thank you, Barbara. And it's really nice to be with you guys all this evening. Before we get started into our slides and going over Team Birth, we wanted to do a quick pulse check with everyone. So I believe Elizabeth is going to put a link in the chat for an idea board. And when you click on this link, what it should take you to, oh, and Elizabeth's going to share her screen too. Elizabeth, you are full service. Thank you. This is a pulse check of just aligning with the priorities across the state of Oklahoma. Would love for you to click on one of those little green plus signs and put in what the priority for your particular organization, your health system, or even just yourself, what your priority is. And that can be, I'm asking for it across the quadruple aim, which is either enhancing patient experience, improving population health, so it's focused on outcomes, reducing healthcare costs, or improving work life for healthcare providers. Great, so we got one up there already, increasing staffing and communication, decrease nurse turnover. Great.
And all you have to do is go to the link and click on the plus signs to add a sticky note. And if you agree with one, you can click on the note and click on the thumbs up. And when you close it, it'll automatically populate.
So we'll give people a minute or so. Awesome, I see more coming in. More voice for patients during delivery. When you improve health of population, you reduce cost and complications. I love that, could go in both categories. Outcomes. A lot, great. So a lot on patient experience. There's somebody for reducing costs, thank you. Now, as we get into talking about Team Birth in just a sec, I will share my screen. Team Birth really does speak to this quadruple aim, and it is an intervention directly for patients. I mean, that's how it started. But as you'll see in our data and as we talk through, it makes a big difference to clinicians as well. And so we'll highlight some of those as just seeing this priority around decreasing turnover, decreasing burnout, and more support for clinicians. So I'm going to go ahead, Elizabeth, if you'll stop sharing your screen. Definitely, if you have that still up, feel free to continue to populate it. It's really helpful to see where everyone's at tonight. And I am going to switch over to sharing my slides. And I promise you'll get to meet Trisha in just a second here. All right. Can everyone see slides that says Ariadne and OPQIC on them? Yep, Trisha's shaking her head. Yes, that me. Okay, great. So we're going to update you on Team Birth and specifically what it is. Many of you have heard about it before, so we won't spend a ton of time on that, but we really want to highlight some of the work we've been doing in the past few months, especially around this cohort 1. So just as a background, Team Birth was created at Ariadne Labs. Ariadne is a joint center between Harvard School of Public Health and Brigham and Women's. This is a partnership with the PQC as well as Department of Health and funded through one of the HRSA grants. Okay, so at Ariadne, there are 5 main programs and the Delivery Decisions is one of them. The programs range from birth to end of life. And at the Delivery Decisions Initiative, it's our vision that we'd have a world that everyone could choose to grow their family with dignity. And the reason that we use that word dignity is just what many of you highlighted today, is that outcomes alone are not sufficient, but a person's experience also matters. I'm actually going to pull over the chat because I see some coming in and want to make sure if I need to notice that. Okay, great. So Team Birth. Team Birth is an inpatient solution. So Team Birth is focused on care during the point of entry. So that might be triage or labor and delivery, all the way through postpartum and to discharge. So Team Birth is really trying to accomplish these. I'm going to highlight 3 things that it's trying to accomplish. The first is empowering each person's expertise. So as you know, labor and delivery and postpartum care, these teams come together randomly. It's really hard to predict when people go into labor. And the way we work with shifts is when you're a nurse on that day, you may be working with a different provider every day that you're on during a month. And so we have to create a way in which each person on the team is empowered to use their expertise to benefit the patient care. So the first most important expertise that we're trying to highlight is the patient. Often in healthcare, we do a lot of telling patients what needs to happen or doing care to them. And we don't have as many kind of structures in place to really empower them to live, to use their lived experience to inform the care. So that's really empowering the patient. We want to empower the nurse who's at the bedside for the most of any clinician during that labor stay especially, but also has unique expertise as having a different knowledge by being there directly. And then the providers, whether it be a midwife or physician, obviously has special training and knowledge around disease processes or in surgery that is really necessary for safe care of patients. So empowering people in their expertise. The second one is that reliable communication. So many of you know that are probably reviewing the maternal mortality cases within your state or just familiar with Joint Commission. But when Joint Commission reviews their sentinel events, they've posted on their websites about 80 to 90% of them have a root cause failure in teamwork and communication. So, and probably many of you have experienced these challenges in your work. So Team Birth is really aiming to create a reliable, consistent mode of communicating these expertise across the team. And Trisha will show you a little bit of what that looks like. And then lastly, the goal is to arrive at shared plans. And so the sort of word we use for that is shared decision making. And that would be like the goal or the outcome of Team Birth. And if anyone has questions along the way, feel free to use the chat, but we will also do another idea board at the end. So I want to share a couple of principles with team birth that are really, really important to understand, because when we're asking people to do anything different, one of the first normal human reactions is resistance, because change is hard, and change during a pandemic is even harder. So one of the main principles that was a part of the very design of team birth was simplicity. And as Tricia shows you what the kind of huddle and board design looks like, hopefully that will come forward really strong, that this team birth is not complicated. It should not be hard to learn or to do. You should be doing a lot of these things anyways, and it's creating a structure for you to be reliable every time. So simplicity is one of our principles. The other one is teamwork. Again, at the very first aim I shared with you about elevating everyone's expertise. We have created team birth so that it really empowers the whole team to perform and be their best selves. So that's one of the other principles that's really important. So when we talk about team birth, like what actually is it? It's basically a combination of team huddles. So this is when the team comes together, patient, provider, nurse, at minimum, they come together, and we have this structured communication. So there's certain topics they talk about, and it's documented in a certain way on a very large dry erase board in the labor or the postpartum room. So that's what we say like is team birth. We also have decision-making tools that are really supportive to the shared decision-making process. Now, with the creation of these tools, we know you can't just throw them at people and them to just do them automatically. So we do have specific implementation and measurement recommendations that help enable a system or a healthcare facility to really do team birth the way it's intended. Now you can see at the end of our logic model is if this is done, what you should find, which I'll show you some data in just a second, is an improved childbirth experience and outcome. Okay, so from our pilot trial, towards the very end, I will show you like a journey of our research so you can get an idea of what's currently out there and what's coming. But this is the data from our pilot trial, which is actually still in review, but should be published soon. So thinking back to that quadruple aim, these are some of the metrics that we're reporting out on for patients. So patients said, so 90% of the patients that we surveyed, and this was across 4 hospitals in the United States, including St. Francis and Tulsa, 99% of them said that they had the desired role in making decisions in their labor. 99% of them reported clear communication with providers and ability to share care preferences. So one of our concerns was, would patients even participate in these huddles? So that's where that question's coming from. And then lastly, the question that we valued the most and really strived to achieve was that 96% of patients felt their preferences made a difference in their care. And not just having preferences, but the word that was in the question was sharing preferences. And this we felt like was really a huge success, that patients were invited into the conversations and they felt like those preferences were incorporated into their care and it made a difference. Now, that's on the patient side. But several of you put stickies right away around nurse turnover, around burnout. And that is something I didn't share with you, but my background is nursing. I was a labor and delivery nurse out in Washington State for about 14 years. And clinician well-being is a crucial part of quality improvement. It's part of making the system work. And so I want to share with you some data we had on clinicians. So for the clinicians we surveyed, which are physicians, midwives, and nurses across these 4 facilities, they all delivered about 3,000 to 4,000 babies annually. 94% of them felt team birth improved care for their patients. 90% of them would recommend team birth to other labor and delivery units. And 88% felt like it clarified C-section decision-making in non-urgent situations. So these numbers, to be very frank with you, were way higher than we expected, because I've done a lot of implementation, or I could look at Barbara right now. Implementing is really hard with clinicians and they tend not to like it. And so having such high numbers, these were taken 9 months after we implemented, we felt like was a huge success. I'm going to switch over to Tricia to talk to you just a little bit more specifically about team birth, and then I'll follow up at the end with where we're going with future research.
Excellent. Thank you so much, Amber. So I'm very briefly just going to do a high-level overview of what exactly is team birth and what is it that we're trying to achieve through these behaviors. And so as Amber mentioned, 80 to 90% of Sentinel events, root cause analysis shows comes from a breakdown in teamwork and communication. And it turns out these 4 structured behaviors right here are really meant to elevate the team and to improve communication, beginning with the team members. So promoting the team, that's where everybody in the room, specifically the patient, the nurse, the provider, have the opportunity to, and the permission and the opportunity to speak and ask questions and share goals and ideas. The second is we're really trying to elicit patient preferences. And this is attending to not just clinical objectives, but also lived experiences. So we really want to understand from the patient's perspective, what are their desired goals for birth, for their labor experience, and if they have any fears or things that they would like to avoid. Third, we really want to make a distinct difference and distinguish between mom, baby, and progress. And in all of our team birth behaviors, as well as our tools, it's really broken down in that way so that every time the team comes together, the patient really knows what to anticipate, that we're going to touch on how are things going for mom, how's her energy, how are things going for baby, looking on the monitor, and how is progress coming along. And if there's a concern in any one of these, what are the interventions that we're doing to help improve? And then fourth, and possibly one of the most important that we found from patients' feedback, is really setting clear expectations for when the team will come back together. Now that will always be very varied depending on where the patient is, either in labor or in her postpartum care, but it provides the psychological safety of knowing that what's going well, what's concerning, and then the next time that we're going to come back together as a team to really address these behaviors. You can go ahead and advance to the next slide. The main difference with team birth, and as Amber mentioned, a lot of this is already occurring, but typically how it occurs is out at the nurse's station. And so there's often these two-way conversations. So it's provider nurse, nurse patient, and it goes back and forth. What we're trying and aiming to do is really structure these conversations around the patient so that the patient is really the primary participant and able to hear all of the communication that is going on for whatever event that is at the moment, whether it be admission, whether it be at any point that there's a concern in the patient's labor progress, in her postpartum care, or at discharge and before delivery. So this is where we really want the team to come together. We discuss the goals, we hear patients' preferences, we honor that every patient has a voice in their care. We want to elevate and empower them to speak up. And then we anchor it on what Amber mentioned was the shared labor and delivery planning board or postpartum board. And that really provides that kind of the anchor of communication. And it allows patients the opportunity to read, reflect, share, and then ask questions should they have any. Okay, Amber, you can go on. So it's really quite an honor and very exciting to share how Oklahoma has been a participant in team birth since really its infancy during the pilot phase at St. Francis Hospital beginning in 2018. This year, during the pandemic, we did launch at Hillcrest and OSU, and they're having great success. We are still in the implementation phase and collecting data. And then we are also so excited and eager to collaborate with OPQIC over the next 3 years. And we will be implementing in all 46 hospitals throughout 3 different cohorts. So the first cohort, our goal is to launch in the spring of 2022. So right now we're in that preparation phase with their teams and their hospital sites. And then the second cohort will begin in 2022, or excuse me, we'll start recruiting the second cohort in 2022 and engagement. And here is a list of the facilities that are participating with great enthusiasm, despite this very difficult landscape in which we are currently living and working with the pandemic. These are front runners and leaders in the state of Oklahoma. They have showed enthusiasm, engagement, and we are very honored and eager to help support their teams through the implementation process. And with that, Amber, I'll go ahead and turn it back over to you.
All right, sorry, it took me a minute to unmute. And Barbara is correct. We did launch officially with Hillcrest and OSU in 2021, but we began working with them in 2020. So going on, I just wanted to give you an idea of the research that's happening alongside this project. Now, you probably, as you heard about the project, like at face value, it makes a lot of sense. Talk to patients, listen to them, elevate their role in their care, honor their expertise. And this is a lot of how we design it in response to a lot of the qualitative work that's been done around maternal health in the past few years. Around listening to mothers is a really great study, especially looking at maternal mortality and the rates of morbidity and mortality to women that are Black or Indigenous. And often what is seen in that qualitative work is not being heard. So it makes a lot of face value, right? But also we want to really be able to demonstrate what the difference it's making. So you can see in that early pilot phase, or in the past, what we were testing in those 4 hospitals is really acceptability, feasibility. Would clinicians do this and would they like it? Would patients do it? Would they like it? And wanting to make sure there were no safety concerns. So we did collect clinical outcome data. We have 3 manuscripts that are coming. One I linked there, which will be available in the slides, as well as we have 2 that are in review. So the primary outcomes, as well as an implementation paper. So those hopefully should be out soon, but the review process has been really slow with COVID. The current research that we're doing is on these 3 kind of pathways. One is a safety attitudes questionnaire. This is a really well-known utilized tool, and we're using this with the clinicians to look at how team birth, when you come together and you're communicating better as a team and having shared expectations, does that improve the safety culture within clinical teams? So that is one aspect. The other is a scale that we're using. It's called MADAM for short, but it's the Mother's Autonomy in Decision Making. And again, we're looking at people who have teen birth. Do they have higher autonomy scales than those that do not have teen birth in their care? And then lastly, looking at outcomes. Now, this is going to be tricky because, like we said, we started implementing in 2020 to 2021, and COVID has played a huge impact. And as Joy shared, you've had 5 maternal mortalities already this year as compared to last year. So outcomes might be a little bit difficult to ascertain or to really pull out, but that is what we're currently studying. In the future, which is the work that we're doing within the whole state of Oklahoma, we're going to be focusing again on that mother's autonomy and decision making. But we're also using a scale called the Healthcare Relationship Trust Scale. And part of this emphasis in trust is that that's one thing that we believe has really been challenged in the past few years, especially, well, it was already a problem, trust within the health system, but it has become really exacerbated through COVID, through the just the reality that we have in such a politically and medically divided community around vaccinations, around healthcare advice. And there's just a significant lack of trust. And in trust, it goes both ways, from the patient perspective and also from clinicians. So that is a scale that we will be using to test whether having transparency of information, does that help you to trust your clinical team more or have more trust in the health system? So I hope that gives you an idea of where we've been and where we're going. I'm happy to answer any questions. And then I believe I should probably stop sharing. So Elizabeth can post our next idea board, which is going to really capture some of those questions and concerns people may have. So that first question is, what resonates with you? This can be you personally, this can be your professional role that aligns with what you're working on. And then additionally, that other side is, what concerns do you have? What questions do you have? And I don't know how much time, Barbara will tell me how much time we have to address them here. But I think
go ahead and go to the link in the chat that Elizabeth posted and start entering whatever you want. Just click on the plus and create the different post-its, and then you can also put a thumbs up if you like one of the post-its. So go ahead and start entering information onto the idea board.
So I have a couple comments of love the elevating everyone's experience framework. Yeah, that tends to improve job satisfaction, especially we've noted it around nursing in our pilot trial. But patients obviously from the data really, really love it as well. Elevating trust with patients and clinicians, the simplicity. We have a concern, will this take more time for clinicians? That's an excellent question. And I wish I would have thought of it in the beginning just to start there. So in the beginning, as you're learning anything, within the first month, it might be a little clunky and take you more time. But the clinicians who have been doing team birth more than a few months say that it actually saves them time. We've not collected any like pager or texting data. I wish we had. Because if you do a huddle and you do a good huddle and you go over the plan and when you're going to come together next, it reduces the amount of pages that you get in between the huddles because everybody's on the same page. So that has been really consistent feedback from our clinicians. The hope you can scale quickly even during the pandemic. That is a really notable concern. As you all know, the staffing challenges right now, or just even the challenge on the health system to manage the patients is really, really tricky. I will tell you we're implementing very closely with 4 sites since 2020 to 2021, and in a total of 19 sites this year. Implementing team birth has actually unified their teams and brought greater job satisfaction, greater meaning, because I think they're reporting feeling more aligned, that they're prioritizing patients and that they're having less conflict within their teams between nurses and providers. So, but very notable challenge and something that we're really paying a lot of attention to and also being really flexible in our implementation timeline. Barbara, should I keep speaking to some of these or you have to cut me off?
A couple more minutes. I think you're good.
Yeah. So how can team birth promote health equity in disadvantaged communities? That's a really fabulous question as well. One of the things that is really important about team birth is that every patient who comes in for their interaction with the healthcare team, they get the same opportunity to participate in decision-making. They get the same care, that it's reliable every time, every interaction. And that is really, really important, that we're not just educating patients who look like us, sound like us, speak English, but every patient is getting the opportunity to have that information. So I don't have the final data on it because we're obviously still collecting data, but what we're seeing so far is that our Black and African American respondents are actually, who have team birth, are reporting higher autonomy. So this is a huge win because that's the direction we're hoping it goes in, but we'll know more as we continue to collect data. Change in hospitals is hard. Yes, if I could high five that person, I totally agree with you. Culture change is hard. And I told you team birth is easy. It should be easy. You should be doing these things all the time, but we're not reliable as humans. And so we need operational systems to support us. But it also creates a culture change because once you start getting people to actually talk together and talk with their patients, it changes your hospital culture. And that does take more time, and that is where the challenge is. And implicit bias in data collection. Yeah, so this is a difficult thing to collect in data, and right now we're not able to do it in a way that we can link to patients and getting that data from clinicians. So it's definitely an opportunity in the future that we care a lot about, but right now what we're primarily focusing on is hearing from patients. So we are stratifying all of our patient data by race, ethnicity. We've got immigration status, language. We offer our survey in multiple different languages. In Tulsa, it's in English, Spanish, Chuukese, and Zomi as their most common languages. So we're focusing most of our research attention on hearing directly from patients and not studying implicit bias through a clinician lens at this point. And resonates. Let me read a few of these. Patient-centered care with preferences shared and acted upon. Team birth would have improved my birth experience. I agree, mine too. Nurses are not caught in the middle of conversations. Yeah, this really helps with nurse satisfaction. It does. Especially in postpartum, nurses end up chasing providers down a lot. And by just being a part of that huddle, it really minimizes a lot of the excess busy work that they're doing. Improves nurse resilience. Everyone is part of the team, not just clinicians. I like the idea board. Yeah, that was Barbara and Barbara's team. They suggested it. So good job, Barbara. Validating trust or valuing trust and a process to make what we should be doing easier and more consistent. Yes, I truly believe all of you here are evidence of this. There's an amazing amount of people in Oklahoma that are trying to make care better for your birthing families. And I really, truly believe every clinician went into this work because they wanted to make a difference to patients. I really do believe nobody went into med school and went through all that or nursing school to be a jerk. People have a lot of pressures and it's hard to be a clinician these days. And Team Birth really sets them up to be their best self. And that feels good. Providers like it because their patients also really like it. And that positive feedback mechanism is really satisfying. Like people want to keep doing it because we all like to do a good job. So I could keep going on forever, but you guys have other agenda topics, so I should stop talking. I'm happy to answer any other questions directly. You can always reach out to us over email, and really pleased and just honored to partner with the state of Oklahoma. And thank you for having us here tonight.
Thank you, Amber. I do want to highlight, someone put any response from family members or partners. So there are surveys that are distributed. Amber mentioned, and so sometimes they do receive responses from them as well. So I'm going to go ahead and pivot to our next agenda. We certainly value our partnership with you all too at Ariadne, and thank the SMHIP program funding that enables us to do this work. So I'm going to turn it over to Denise Cole, who's going to talk about, provide a short update on data. We don't have all of our data. We're working on our data report because we just received one of our largest hospitals' data last week. So we have a little bit of information tonight to give you some short update on our OMNO data.
Yeah, thanks, Barbara. So basically, as Barbara had mentioned, this is hot off the press. So we're going to label this as being preliminary. We have a lot more that's going to be reported in our reports that will be out by the end of the month. But here's just a little teaser for you. Just so you're aware, our OMNO participating hospitals have been continuing their work even during the time of the surge. Some of our hospitals have been achieving some great strides, and we are going to be having a meeting on November 12th where they're going to be able to share some of their successes and learn from each other, and we'll have more information about that meeting coming up at the end. So just a little bit of background for our Q2 2021 data. So this is data with date of delivery or date of birth from April, May, and June of this year. We received a total of 81 records, which represents 78 women with opioid use disorder or substance use disorder, and 80 newborns. So there were a couple of multiples reported during this period. 69 of those newborns were greater than or equal to 35 weeks. So we refer to those as our opioid exposed newborns. Those are in the denominator. We had 9 total hospitals that reported cases and 2 hospitals that reported that they didn't have any cases throughout that period. If you look at it from insurance status, we have by far more Medicaid patients represented in this data set than other insurance, as you can see, especially when we're looking at the baby. So for our babies, we had 80% of those were reported to be on Sooner Care. If we look at it by race and ethnicity, it pretty closely resembles what we have as our general population. Some of our moms and babies, we have the option on our form to select more than one race. So you might notice that those numbers don't quite add up. They're a little bit exceeding our total, but you can see there our breakdown. One of the measures that I wanted to point out was we asked the question on our form, was the baby reported to DHS? And what we mean by that question is, or that was DHS contacted in order to make a connection with this family. And so as you can see, each of these bars represents one of our reporting hospitals. So we have the 9 hospitals that are represented here. And the purple bars are the number of yes, this baby was reported to DHS. The green bars is no, the baby was not reported. And then there were a few, one hospital reported 1 baby, another reported 2 babies where it was either unknown or they left that particular question blank. So as you can see, by far, we have most babies that are reported to DHS. In this particular sample, we had our total of 69 opioid exposed newborns, and 52 or 75% of them were reported. So we had 14 babies where the hospital indicated that no, there was no report made. And most of the responses that we get for why there was no report made was that they're still trying to interpret current Oklahoma statute, which our next presentation is going to go over that quite a bit. So one of the reasons I wanted to present this particular slide was because it is kind of leading into the work that that group is doing. And then we had 10 responses that indicated that they did not know why there was no report made. Another question we ask is, did DHS take custody during the birth hospitalization? So the purple indicates no, the green indicates yes, and then there are no grays for unknown or blank. So as you can see, we have 14 babies that had a yes, DHS did take custody. That represents 20% of our 69 opioid exposed newborns. We track discharge disposition and asking the who the infant is discharged to. And so the percent of the opioid exposed newborns who go home to their biological mother, we have a little less variety among our hospitals during this reporting period. On the left graph, each of the bars represents one of the reporting hospitals. So a couple of our hospitals, all of the babies went home to biological mother, and then the percentages go down. So you can see our collaborative wide rate on the graph on the right. So we had a little bit of movement with June having the greatest percentage of newborns who went home with their biological mother. Overall for Q2, we had 49 of the 69 infants, or 71%, go home with mom. Another measure we track is the percent of women with opioid use disorder during pregnancy who receive medication-assisted treatment or behavioral health treatment. So did they have some kind of a treatment before they arrived for their birth hospitalization? And so you can see on the graph on the left, again, each bar represents a hospital. Overall, collaborative wide, we had about 60% of women already engaged in treatment prior to their birth. And you can see the trend over time in the graph on the right, with going up from January to June, we're on an upward trend. One of our interventions that we're promoting at the hospitals is a Chest Health app that is aimed to help to connect women to services and to treatment. And so we're hoping that as hospitals begin utilizing that app, that we'll see more of a connection and more referral and more engagement. And the last data slide that I wanted to present, mainly because I know there are some providers on our meeting tonight, is we track testing for sexually transmitted infection. Most of the other infections that we track have a pretty high rate of testing sometime during pregnancy or during the birth hospitalization. But what we're noticing is that we have a much lower reporting of testing for hepatitis C virus. And so I just wanted to show this graph. There hasn't been a lot of movement upward yet, but we see for Q2, about 62% of the women in our sample had some kind of testing either during pregnancy or during their birth hospitalization for hepatitis C. So if you have any questions related to our data, feel free to put them in the chat. I think for time, I'm probably going to go ahead and transfer over to our next presentation. Barbara, did you want to introduce that group?
Yes, thank you so much, Denise. And again, our data reports will be coming out soon, so you can see the full report with more explanation. I want to now turn it over to Terry Cook. Terry is a Senior Program Associate at Children and Family Service Family Futures. She's been in that position for 3 years, and she's leading Oklahoma's in-depth technical assistance, also working with South Carolina, Michigan, and North Carolina. Terry previously served in management roles in a public child welfare agency in California and with 2 philanthropic organizations devoted to improving outcomes for families served by the child welfare system. So I can tell you that without Terry, we would not have been able to do all of this work. So we've kind of melded this into our Oklahoma Mothers and Newborns Affected by Opioids. And these are a lot of the structure measures and culture changes that also need to occur is what this team is also working on. So I'm going to let Terry provide an update for you guys so you have a little idea of what's happening in Oklahoma. Thanks so much, Terry.
Thank you, Barbara. So on the next slide, we've been at this for about a year. And again, as you've heard, the goal of this work with in-depth technical assistance is to create a system that's more compassionate, that serves both mothers, infants, and families in a safe manner, but also gets them the care and supports and services they need. So you'll, what we'll do during this time together is review the recommendations to date, discuss some implications, and then talk about next steps. On the next slide, and the next one. So what do we need to do in Oklahoma to be able to, sorry, I'm needing to change something on my screen. There we go. To create more flexible options for families that we again heard earlier, and somebody posted about a current woman incarcerated around a miscarriage. What do we need to do in order to really make, again, more flexible options? We need to address the lack of upstream options to increase recovery during pregnancy and to reduce the actual infants with prenatal substance exposure. We need to take a look at the definition of what is an infant affected by substance abuse within the current statutes. And we need to look at a different option than a child abuse neglect report for every infant with prenatal substance exposure. And we'll talk about what some of those options are. On the next slide. Some would ask, so why do we need to change that definition of infant affected by substance abuse? And it's essentially because the current substance affected infant definition limits who gets a family care plan to only those infants with neonatal abstinence syndrome and fetal alcohol syndrome disorder. Many infants that have experienced prenatal substance exposure in their families then don't get receiving ongoing care coordination and supports. To go deeper into this, the current definition of an infant affected by substance abuse in Oklahoma is that those healthcare providers that are listed shall promptly, and I'm going to underline the word report because you'll hear later about the possibility of a notification instead, will report to the Department of, to DHS, instances in which an infant tested positive for alcohol or a controlled dangerous substance, including those with NAS or FASD. On the next slide, you'll see that kind of what's the policy at DHS for plans of safe care is that child welfare staff will obtain the infant's test results. And if the infant's again diagnosed with NAS or FASD, then the child welfare specialist develops a plan of safe care. On the next slide, this is some data from state fiscal year 2020. And you'll see that the numbers, the number of accepted children, so these were infants with prenatal exposure that came into the hotline, was 2,645. About 57% of those were marijuana positive. But then you see this big drop. So again, if the only infants getting a plan of safe care or a family care plan are those with NAS or FASD, that number is at 162. There wasn't full implementation yet of plans of safe care. So those who actually got them were down to 73. And that leaves a great number of children that had exposure, but no plan of safe care or family care plan. On the next slide. Again, this says somewhat what the last slide did, is you've got 162 infants that got a plan of safe care or family care plan that again does that care coordination for both mom and infant. But by having that narrow definition, it means that we had 1,600 infants in Oklahoma that didn't get those supports and services. On the next slide, it's kind of the what if. What if we started doing things differently? And instead of closing out, again, remember that 2,600 was the number of folks who got an investigation. So the report came into the hotline, an investigator went out, but then ultimately the case was closed with maybe a referral for services, but not ongoing coordination. So if instead, in alignment with the Families First Act, that partner agencies, this isn't all on child welfare, but partner agencies step forward to provide a family care plan and care coordination both during pregnancy and postpartum. So again, those supports are there for the infant, for ongoing care, and for the parents and family members. On the next slide, you'll see that part of the work we did at the very beginning is if we're going to do these plans, both during pregnancy and postpartum, what should be the values and principles that drive that? And again, I really love the echoes I'm hearing between the teen birth work, the maternal health task force that we heard earlier, and this. You can just see how it all weaves together so well. So again, I'm not going to read each one of these, but these, I think we continually go back and say, is what we're creating matching up to these values? On the next slide, it's kind of the how. So how are we going to accomplish this? First, we intend and have actually already started initiating prenatal family care plans for pregnant individuals with SUD. We again have some ideas about changing the definition of infant affected by substance abuse to include all substance exposed newborns so that we're capturing that larger group. And for lower risk cases, create a captain notification pathway and family care plan that's initiated and overseen by a partner agency, not by child welfare. I did see in the chat, and we'll try to address it throughout, we believe particularly these last two steps, but actually all three will begin to deal with some of this disparity by not pulling folks into the child welfare system, but getting them the supports they need at a vulnerable time. On the next slide. So how do we do this without overwhelming the child welfare system and having a bunch of kids come into care? And again, that's the starting early and doing this work and much of what we've heard today during the pregnancy itself. On the next slide. So we've got a couple partners that have already stepped forward and have piloted prenatal family care plans. That's both through the Department of Mental Health and Substance Abuse Services. And so that's more at the SUD treatment side, but then also the Starters Clinic at OU. On the next slide, part of what, again, I heard earlier from somebody from North Carolina saying that Oklahoma is just kind of at the forefront, and I would echo that. Back on July 1st, the contracts at Department of Mental Health and Substance Abuse Services changed to include that contractors need to develop a foundation and assist in the rollout of prenatal plans of safe care or family care plans through the statewide and what we're calling the initiative, Safely Advocating for Families Engaged in Recovery or SAFER. On the next slide, you'll see some of the details. I won't go into this. I think we will be sending out the slides afterwards, but it gives the specifics for each contractor on what they need to do in order to come into compliance and to provide those services. The key piece is the one that's underlined there, that they'll offer a family care plan to individuals who want to become pregnant within the year, who are pregnant, or who are in the 4th trimester postnatally. Again, a huge shift, and you can see at the bottom which contracts that those referred to. So this is a quick graphic, I think, in pictures, so like to add those in. So how does this actually look? So SBIRT, so screening, brief intervention, and referral to treatment would happen at prenatal visits or other points of contact with pregnant individuals. A referral to treatment for assessment and or treatment if needed would occur. The treatment agency would develop that family care plan where the parent is the holder of the plan. The parent decides who else to share that with, and hopefully sharing that with other providers. In the best scenario, the plan is shared with the hospital prior to the birth event. That again, the woman is advocating for herself, is coming in prepared, is essentially bringing in that family care plan, as I heard another jurisdiction call it, a recovery resume. So they're saying, here's what I've done to try to change what's happening in my family and to create a safe and nurturing place for the entire family. And again, if all is going well, that family care plan informs discharge planning and evolves to a postpartum family care plan for up to a year afterwards. So that again, we're starting at the earliest point in pregnancy, getting that connection to treatment, using things like the CHESS app to know, again, if in fact that folks did get into treatment. And again, hopefully that is going to increase even higher those number of babies discharged home with their families. On the next slide. So it's like we actually have tested this in Oklahoma, and we've got some pretty impressive results from 2 pilot projects. The first was in Tulsa, and this is data through September of 2021. They've had 47 infants born over that time period between October, so it's essentially a 2-year period, 47 infants, 45 of whom discharged home with mom, 2 that went into out-of-home care, and those were actually voluntary placements that the parent chose as they dealt with other things within their family. There's other remarkable data that Tulsa has put together on this. These babies are also not going to the NICU, have been getting Eat, Sleep, Console, and other non-pharmacological supports. And so again, the cost savings that's happening as well as these much improved outcomes are a delight to see. The other pilot is again the OU STARS Clinic, and we'll hear in a few minutes from Sean, and he can give us additional information. So this was through July. The number of infants delivered at that point was 79. Currently 42 pregnant individuals being served. 82% of the individuals were on MAT at the time of delivery, which is considered the gold standard. And again, just a very, very impressive numbers, 91% of the infants being discharged home to mother. A couple of the 7 who didn't go home with mom were due to mom's current incarceration. So again, these numbers essentially are pretty much entirely flipped from prior practice and give us a really good indication that if we can roll this out statewide, we can really start changing again and encouraging women to come in and access treatment because they can trust that that their family will be treated well and that they have a good likelihood of having an intact family. On the next slide, let's go back to the issue of changing the definition of an infant affected by substance abuse so that, again, we don't have 1,000 or more infants that don't end up getting the supports and services. So part of that is our recommendation to change that definition so that it includes all substance exposed newborns. On the next slide. Here's the proposed new definition of an infant affected by substance abuse. And again, this is an infant diagnosed with neonatal abstinence syndrome or determined to have experienced intrauterine or prenatal substance exposure. this language was entirely mirrors the ICD-10 coding that's used in the hospital, so that you would actually have two different systems using the same definition, which would be lovely. On the next slide, this gets further into digging into that definition, tells us NAS, and then specifically on the prenatal substance exposure. Exposure is when there's known maternal use of neuroactive substance at any time during the pregnancy. And then it also gives the kind of whether it's tested or self-reported or the withdrawal symptoms. So this is again what we would be proposing move forward in statute. If in fact that happened, then those 1,602 infants that had prior had an investigation and a closeout would instead be referred to community partners to have a family care plan that coordinates those the care and supports, and that they get again the kind of the warm hug and supports through a very vulnerable time. On the next slide. So I hope you're as amazed as I am by the great outcomes we're seeing in those prenatal family care plans. What can we do to take that kind of good outcome and bring it forward for all infants with prenatal substance exposure? On the next slide. One of the dilemmas we currently have, and again, you saw this in the data that OMNO is collecting, is that right now, the only option is with a substance exposed newborn is to call that in as an abuse and neglect report. And what we're recommending is that for lower risk cases, that we would create a CAPTA notification pathway and a family care plan that's initiated by a partner agency. And we'll go through some of the background and the why of that on the next slides. So currently, again, all infants with prenatal exposure are mandated reports of child abuse to or neglect to DSS, yet few of them are substantiated for abuse and neglect. And again, many are just then closed out with a referral. So our what if is, what if we did create a CAPTA notification option for lower risk families, then the family engagement, instead of an investigation, it's again an assessment, it might be by a community partner. The plan of safe care and ongoing tracking are provided by that community partner, like a treatment provider or healthcare provider. And on the next slide, we'll get into some key points as we think about how we create a CAPTA notification. So this is going back to the language in the federal law itself. Regarding this issue in CAPTA, it doesn't say that these should be child abuse reports. The language chosen by Congress was that the healthcare provider must notify CPS, and that the reports on their own are not grounds to substantiate abuse and neglect. It further said that a plan of, if we go back, sorry, that a plan of care is needed for infants affected by substance abuse, whether or not it constitutes child welfare, constitutes child maltreatment. So again, those 1,600 infants, it may not be abuse or neglect, but they should still be getting a plan of safe care per CAPTA. And then finally, it does not specify which agency or entity should develop that plan of care. So again, this does not need to be a burden, and it shouldn't be child welfare's responsibility only. It can be a shared community response. So therefore, on the next slide, here's what's proposed in Oklahoma. That healthcare provider will gather information and determine whether they should file a notification or a child abuse and neglect report. Both of those would come into the DHS hotline, and that with reports coming in that would go to the for investigations, notifications would be assigned for diversion. And sent along again to the SED provider for a family care plan. On the next slide, there's a little bit of nuance that the one safety net that both healthcare providers and the child welfare agency thought was important was that it may be, again, that family coming in for the birth, that the hospital may not have all of the information. So the healthcare provider could choose a notification thinking it's a low risk case, but as the hotline person is typing it in, up pops information that the hospital didn't know. So hopefully they're rare cases, but potentially that hotline investigator could convert notification into a report if there was information not known to the hospital that changed that risk profile. So again, just a safety net that both sides thought that would probably be important. On the next slide. These are the types of things, and this isn't final as yet, but these, if we go back one more, are the kinds of things, or what we intend to do is build an electronic portal. Connecticut and a few other states have created it so the healthcare provider could be asking a set of questions, and based on those answers would be saying, okay, that fits the criteria for a notification. This would fit the criteria for report. Again, on the left are the risk factors. If the parent has not made preparations for the newborn, that they might have had a very recent entry to treatment or an untreated co-occurring mental health disorder that impairs parenting. They may have family and community supports that they're not using. It could be that the infant has some complex medical care and the parent hasn't received the training or been visiting while the child's in the hospital. On the flip side, we want the healthcare providers also to be looking for strengths. So it's the flip of all of those. If that parent has created a safe sleep plan and car seat and items for the baby, have been stable in their recovery, are using the community supports, and even if there is some medical complexity, have done the training, have been visiting, then again, that would lean toward a notification that would still, again, get them into a community provider that provides supports and services. It's not a kind of investigation or nothing. It's a different approach based on the profile for which the families come in. And again, hopefully, if they got one of those prenatal family care plans, they're coming in kind of stabilized, and this just helps them on that continued journey for recovery and connection for the entire family. So that was a lot. We've been at this for a year. On the next slide, I think we're going to go to the idea boards. We're going to drop it over in the chat and essentially say similarly kind of what resonates with you, what sounded good. Are there parts that concern you and that you think will be a barrier to implementation? Let's see if folks can drop in kind of what excited you, and again, what concerns do you have that may present barriers? Potential for increased family support for families and more nuance. I think that nuance is so important. And that, again, part of the thread I'm hearing through tonight is that families are heard, they're respected. I really love that can grow their families with dignity. And hopefully those are the kinds of things that we're putting here. On the concerns we're hearing, how will clinicians decide on notification or report? Again, we hope to build an electronic portal that will help with that. Changing the judicial system. Is there legislative changes that need to be made? Yep. Particularly the changing the definition of a substance-affected infant. We are going to continue to work with partners to identify who thinks this would be a good idea, who might have concerns, and to weave that into the work moving forward. Let's see, on the things that were exciting, that all who are exposed can receive family care plans. Again, yes, that we're getting those infants into care, and that people feel like the system that they're accessing is helping them kind of move forward in a hopeful manner, not in a punitive manner that makes them want to hide their substance use disorder. There will be difficulty in changing the culture. I can almost guarantee that. The training of all disciplines, and in fact, I'm glad you put that there because Sean is up next and we'll be talking about some of the amazing work he's been leading to do that exact work across systems. We definitely have folks from the court improvement project and parent attorneys and others that are on our work groups, but we think, again, this will take some time, but we've taken a good year to try to figure out what's the best fit for Oklahoma in this. And we're hoping that we got it right, or close enough to right that we can work with others who may have some concerns to continue to adjust it to meet the needs of all organizations and families. So with that, I think we will turn it over to Sean. And thank you so much. It's been such a journey in Oklahoma. I've been pleased to be part of it, and hearing again all the amazing presentations tonight. Just really happy. There's so much good going on, and continuing to weave these pieces together to make for a system that instills hope. Thank you.
Thank you so much, Terry. I can tell you we wouldn't be in this place without your guidance and leadership. So we appreciate it. And I am going to, the exciting news is we already have these family care plans. Some people are already using them, and Sean is going to talk about some training that is just rolling out for providing family care plans. So just a brief thing, just want to tell you, Sean is the project manager for the Substance Abuse Treatment and Access to Recovery and Supports Program, the STARS program, with the Oklahoma Department of Mental Health and Substance Abuse Services. So thank you, Sean.
Kind of like Terry was saying, is we have seen a lot of great results with these organizations that have implemented these family care plans and really used them as an ability to both move upstream in how we serve pregnant individuals, but then also as a way of empowering the family unit as a whole to really lead and direct their care and their support, and really serve as a mechanism to again give them every resource, tool, and support they need to be able to live out their lives in the community of their choice. So with that being said, we were like, okay, we're seeing this success. How can we roll this out statewide? How can we make this culture shift, or this way of serving these families, available to providers across the state? So Terry talked a little bit about some contract language that we changed for substance abuse treatment providers that will require them to provide family care plans to pregnant individuals and those who are considering becoming pregnant. But again, we want to make sure that, okay, we're not just going to say, hey, you will do this. We want to make sure we provide you with the training and the tools and supports to be able to implement a family care plan. So a phenomenal statewide family care plan team got together to really develop a set of training modules to kind of be that first step towards orientating providers in the realm of family care plans. So we can go to the next slide. So just a quick update, as of October 15th, when it came to this training that we really wanted to disseminate statewide, there's a couple of big rocks that we have accomplished in a little under 6 months. And the first is the creation of what we call a statewide family care plan document. You know, when it comes to the family care plan, we are it's super important that we communicate that it's not a binder per se. It's not a document, that is truly a way of thinking about how we serve these families. But we wanted to make sure that we provided those who are kind of taking their first step into this whole family care plan world with some type of document and resource to say, hey, here's a good starting point for facilitating those conversations with these families. So we created a universal document that is going to be available, of course, to all providers across the state, and understanding that there will be tweaks to it so that they can kind of make it their own, so that it will be unique to their communities, be that geographic or otherwise. Then we formed content teams that really took a look and said, okay, how do we walk somebody from, okay, I've never heard of a family care plan, to where I'm ready to begin implementing this within my organization. So these content teams got together to really determine both the training design, the structure, and the learning objectives for these 4 training modules that we're going to be releasing. And then we reviewed and approved the e-learning template, just the overall template design for these training modules, and developed the transcripts as well. Just again, to make sure that the language is in alignment with not just family care plans, but is in alignment with the larger movement that's happening across our state in regards to how we serve these families. And then we have an opportunity to shoot testimonial videos as well that are going to be a huge part of both this family care plan training that we're doing, but then also in just both marketing the whether it's the STAR clinic or the other services happening across the state, but then also using them as a stigma reduction tool as well, to really, again, kind of bust that stigma around serving pregnant individuals dealing with a substance use disorder. Next slide. So I won't go through this entire timeline for time's sake, but just to let you know, this team got together and really laid out how do we get, again, from A to Z. And so the real point I want to highlight here is that this week, the first module 1 is going to be released. And I'll talk about what each module is here on the next slide. But from there on, module 2 will be released on November 1st, module 3 on the 15th, and then finally module 4 on December 1st, with the goal of by January 1st, all 4 modules are made available to providers across the state so that they can begin to learn about family care plans and start implementing that within their organization. And then I would also highlight down at the bottom that we also know it's super important that we can't just say, okay, here's this training, boom, attend that. Now you're family care plan experts. You know, we want to make sure we utilize the expertise of those in the field in our state who have already walked this journey. So there's going to be TA and coaching that will be happening throughout this entire process. There will be peer learning opportunities, community of practice opportunities as well, to really help, you know, walk side by side with these organizations that are taking this step to, again, kind of like it says on the slide, to really create this culture shift within the organizations and within their communities on how we serve these families. Next slide. So here are the 4 sessions that as the team got together, we really felt like if we were going to launch this type of training, there are 4 modules that will be critical to making this happen. And we always, I love how when the team got together, they said the first thing we have to do before we start talking about practical application or documents or anything like that, we need to first talk about why do we even need family care plans? You know, so really talking about the data behind it and that place there, but then also talking about the values and beliefs that drive a family care plan. And that is something that if you talk to any organization that has implemented family care plans, they will tell you the key, the critical component that makes it work is the alignment of the values and beliefs when it comes to serving these individuals. That we are truly there to empower them and to equip them as far upstream as possible with every resource, tool, and support necessary throughout their pregnancy and beyond. So that's what that first session is about. And again, that will be made available to everyone, not just substance abuse providers within the medical system, community members, faith-based organizations. We really want to get that piece out there to everyone of just what are the values that drive that family care plan. And then there's the second session that revolves around the initial walkthrough. It takes that initial document that we developed and walks the learner through that piece. Okay, what is this for? How does this align with the values and beliefs of the family care plan? And then how do you utilize this as a tool to facilitate that initial discussion? You know, and again, that is a thread that exists throughout all 4 modules, is that we do not get stuck on the form. We do not get stuck on the process. We get stuck on the values and beliefs that drive it. That third part is around practical application. And that's where the individual is going to get a chance to actually watch an in-person session. You know, I don't know if you're like me, but I can read stuff, but seeing it just makes it stick even better. So they're going to get an opportunity to see one of our providers walk through a mock initial session with an individual so they can see not just the form piece, but they can see all the other parts that go into that session. You know, the language that is used, the tone that is used, the feel of the session, all those things that really communicate the values and beliefs that we have. So they're going to get a chance to see that and then learn how to facilitate those sessions themselves. And then the fourth and final one is organizational integration. You know, being able to take those things that you've learned and learn how to infuse it throughout your entire organization. You know, we talk about all the time when it comes to family care plans that it's a shift in thinking and it's a shift in culture within your organization. So you're going to get a chance during that session to hear from some of the champions who have taken this from what was just literally an idea or a belief that pregnant individuals should be equipped as far upstream as possible. Take that idea and then bring it to something to where they're literally changing how families are served and how they are equipped to be able to care for themselves and their infants. So you're going to get a chance to hear from them and then hear how they took it throughout their organization to where this wasn't another program that's done, that this was truly a new way of thinking and a new way of serving these families. Next slide. So where are we at now? We're finalizing the testimonial videos. Those are almost wrapped up. We are promoting these sessions left and right, letting people know, hey, they're coming, they're coming, they're coming. And then we are beginning to map out the technical assistance and coaching, and also what manual and documentation support are going to be needed to organizations that are wanting to do this. So we're mapping those things out right now. And then next slide. So the last thing that I'll leave you with is session 1 is coming out this week. In fact, I was talking with our e-learning team this afternoon, and they are waiting literally for one more green light, and they're going to publish it. And as soon as they publish it, man, we are going to blast it out to anyone and everyone so that they can, again, start with learning those values and those beliefs that drive how we serve these individuals, because we know that, I mean, it starts with that, and that's what, you know, trickles through everything that they do. So again, it's coming this week, and I can't wait to be able to give that link to you so that you can participate in this family care plan rollout. And I think that's the end of my presentation.
Thank you so much, Sean. Yeah, so you all will hear from us, and you can also come to our website to get links to the training. Denise, if you want to go to the next slide. If you have any questions or any other business, you can unmute yourself or put something in chat. We told you we had a full agenda tonight, and we did. I'm just turning in the dark here, sorry. We do appreciate all of our presenters this evening. We will be sharing the information about the family care plans. They are available at no cost, and we've even thought, you know what about if everyone got a family care plan? So things that may be in the works in the future to improve the care of our pregnant people and the care of our newborns and infants in Oklahoma. I don't see any questions. Wanted to share some upcoming events that we have. We have our Team Birth Cohort Monthly Sessions and our Omno Pilot Hospital Learning Session, again, November 12th. All of these upcoming events listed here can be accessed through our website for upcoming events. So feel free to visit there. You see the link above. If you'll go to the next slide, our upcoming OPQIC Maternal Health Task Force meetings. Next one will be January 18th, and we will see what format we will use for that meeting. So those are our next meeting dates. I think our last slides has our information so that you all can follow us on Twitter, like us on Facebook, join our email list so you can receive the emails for all of our events and occurrences and happenings, and so you can stay up to date on what's happening in Oklahoma and throughout the country. So thank you all again for attending this evening. We appreciate it. And thank you so much to our presenters. Y'all have a good evening.